Thank you, everyone. Thank you, Beth. So, thank you to the NCCTRC for the opportunity to share with the audience and about some of the experiences from the January 10th looting incident, mass casualty incident that happened in Port Moresby. At that time, we had multiple agencies that responded. So my talk would be just basically giving some background on Port Moresby for those of you who are not from Port Moresby, and then also just it'll run through cascade of events that happened, and from the ambulance response, which I think would be useful for the hospital people to see what the ambulance actually did and how the response happened, and then the hospital response, which is a brief summary or just a brief snapshot of Gerehu, and then the POMGen response in summary. So all of the pictures and that I used in this in the slides they were actually from social media and the Facebook pages for POMGen, and also they're actually available already online. So they're not anything that was meant to be private or is private. Okay, so thank you. So what must be, surely there's about 400,000 people, but for St. John Ambulance and the pre-hospital care, we only have actually 6 ambulances in operation at any one time for that number of population. And for in terms of hospital, Gero actually has a 50-bed hospital, and the ED only has about 10-bed capacity. That's including the minor theater and then the short stay areas. In terms of resuscitation, they have only 2 resus beds. Palm General Hospital is a 800-bed hospital with 4 surgical theaters, with at the most 3 operated at the current. Palm Gen Emergency has about 24 beds, 5-bed resuscitation, but the capacity is actually more towards 3 beds than 5 beds, because you need 1:1 nursing, you need monitoring and everything else that goes along with resuscitation areas and critical care. As well as that, we do have another accessory area, which is a corridor, which is more or less a spillover area for people that would be stable, category 3, but need admission. It's an area where we struggle. There's too many patients for us. So of course, you've all seen, or most of you have seen the headlines and everything that flashed across the Pacific and the globe of what happened and the looting that happened. So I won't focus too much on that, but just to say that it happened all the way across the city. So with major incident response, when you're focusing on one area, it becomes a lot easier to manage, especially in the pre-hospital setting. But if it's happening in multiple areas, your danger areas and safety risks elevate, because multiple areas are being looted, and there are mass of crowds and people running and throwing stones and burning shops. So you can imagine, from a response point of view, the complexity is multiplied. On January 10th, the issue started that the police went on strike because of a pay issue. At around 2 p.m., the rioting started, and then the rioters actually also threatened the firefighters that were trying to respond as well. The next day, there were military personnel flown in, and 2 days later, the PM declared a state of emergency. And then there was a national controller that was appointed as the controller for this major incident. And it was reported that there were 50 injuries that were treated at Port Moresby General Hospital, and they ranged from gunshot wound to burns to the fractures and all of that came with the trauma from the incident. So all of that happened in January 10th. So this was actually from the ambulance point of view. So the events that unfolded on the 10th of January, at 10 o'clock, the Charlie crew that was on call gave the first alert to the National Ambulance Center, saying that there's a large crowd gathering at Unagi Oval. and it looks like it's all police officers, and the numbers are getting bigger. And 10:44, the news came out that there's a potential strike and likelihood that opportunists will take advantage of the situation. So the National Ambulance Center sent out the command to minimize non-essential movements. So all the admin vehicles, that's the first measure they took. They grounded all the admin vehicles. They said stay put. All the ambulances be on alert in case that violence erupts, because we know our people. So any opportunity, things may happen. At 1 o'clock, the first ambulance reported the looting at Hoala. And then at 1:30, St. John's was called to attend to a shooting case. This was at 1:30 in the afternoon. But then they realized that it's difficult because they couldn't actually get the scene because of the people that were crowding around that area. The person that made the call couldn't be located. So they couldn't actually locate the person, and it was too much of a safety risk. Because usually with St. John's, if you get a shooting case, they usually call police and then they attend to the case with police in tow as well. There was no police this time. The police were on strike. So immediately at around 1:30 to 2 o'clock, the major incident was declared for St. John Ambulance. And this started the major incident response. So this is the National Control Center. And this is the deputy controller here. And then he was more or less taking control of the operations and movements and all of this that was happening in this operation center. The incident control was their CEO, and he was overall command for them. In MIMS training, we talk about bronze, silver, and gold, and this is their silver and safe area that they were coordinating from. The gold command was where they were linking with other agencies to help with the response. This is purely St. John's. Purely St. John's. So they could only provide 3 extra vehicles. Admin vehicles were also included, and then 1 AFP response vehicle. So they had about 9 vehicles to assist with this entire operations. These are the staff. They were preparing the casualty trauma kits and packing them ready when the major incident was declared. So immediately you can see they were already allocating special resources to staffing, special resources to staff, and special resources to the area in which they operate, the space. But for them, the space is ambulance. So at around 2 o'clock, a decision was made that the ambulance responders should wear their helmets and ballistic vests because there were a number of rumors, lots of rumors being spread. It's chaotic. There's no police and lots of gunshot wounds that were around in the community. But they were just rumors and had to confirm them. So the ambulance couldn't actually move. Situation intensified, and there was a period of a few hours where the ambulance couldn't move because safety was just out of control, and they couldn't go to a site because police was not there to ensure that at least they could be safe as well. There were 14 shooting cases, but the ambulance could only get to 3 of them. The other cases, they went to hospital themselves or never presented to home general. They probably went to private and other cases. And as you can see throughout the afternoon, late afternoon, some of the cases were responding in these suits here. One of our visiting paramedics from Australia was also part of the response as well. As you can see in these pictures, quite interesting pictures, these ones. You can see this one, the patient in the middle is burns, but gunshot wounds and burns were very severe cases. The rest were orthopedic cases and trauma and all of that. And as I was saying, safety is the paramount concern. So safety 1, 2, 3, as we teach in MIMS. When we teach safety in MIMS, we are always talking about safety to oneself, safety to scene, and then safety to the area and the responders the patients that you are going to. Safety to oneself was paramount because there was actually no reliable information. So the ambulance operation center had to filter the information. And then as the crews were responding, they were actually then verifying the information as they went, and they identified spots where they could go and say that they were safe. And then they have a special operations response team. So those special operation response team then went into the danger zone. But there was a backup ambulance in a safe area that will help them to treat and triage and see the patients as they were bringing them out of the hot zones that they were going to bring them out through. So there was ambulances that responded in the where the incidents were really, really chaotic, and then there was another ambulance on standby as well at the border of what we'd call the silver zone, or at least some semblance of safety, because this is actually a responsibility of fire and police. And fire service was being overwhelmed and police was not present. So again, a very, very complex disaster to respond to. You can see the number of calls on their sheet on the computer screen there. And their National Ambulance Center is actually all computerized, and it's an amazing center if you have a chance to visit it. So they had specific teams. So they stated to him that they would respond to cases where they could get a successful callback. So that was one strategy they used. So if you called and they could call you back and then they could talk to you, they could respond. But if you called and then they couldn't get to you, then they can't actually verify and they can't actually get to the patient because they won't know where to go. So if you can be there and tell them that this is where you go, this is how you come, then they would have responded. So one of the key things is when a call is made, they need to make sure that they can still contact the person that made the call. So emergency cases, as we said, the patients were trials and minor injuries, they were actually treated on scene and first aid, and then they were actually advised to come later on the next day or 2 days or so. That's important because we didn't want to overwhelm the facilities, which is key. The priorities were safety, of course, and then threatening to the life-threatening emergency and maternal cases. Operationally, the transport of staff was a priority. Food and water for the responders. Just also making sure that the firefighters were okay. Yeah. So, you know, some of these shops, and we know in PNG, they got looted and actually turned around and provided support for the responders as well, which was very good. And this was all done through WhatsApp communication. So that WhatsApp communication became key for us during the response, and that's one of the other key points. Communication. So we have various groups. One of the group is the National Ambulance Group and Responder Group, and was the main one where they were able to get business houses to support the response, and then the ambulance was able to deliver to Palm General Hospital, deliver the support to firefighters. They will deliver food and water, the basics. And yeah, thank you to those organizations that responded. And as you can see, the additional security measures were put in place at the ambulance service, and then extra security measures in case they wanted to come here and loot. Unfortunately, one of the warehouses that was destroyed at Gero also supported the St. John ambulance, and they lost about 250,000 kina worth of supplies that were stored in that warehouse when the warehouse was burned. So again, emergency supplies and their surge stock was destroyed during this time. It's really one thing compounded another thing on the day. And as you can, this another show of business houses donating food and water throughout the day, and then the next day on the 11th they brought more in. Yes, St. John nurses played a fantastic role. Some of these firefighters had burns on their sleeves, up their sleeves, and exposed skin when they were fighting these fires. They were overnight. They fought the fires from the previous day throughout the night and the next day. There was no substitute crews in PNG. We don't have many numbers, so they were it for the day. They couldn't leave. They fought that fire. And they were exhausted by the next day. So the instruction to these nurses that went out, if they are still working, tell them to stop. Tell them to sit down and have some water, hydrate in the shade, have a conversation with them, make sure that they're okay, treat their minor injuries, get them fed and then let them to continue. They're really doing a heroic job, but we need to make sure that their well-being is considered, and we also remind them to hydrate and feed. This is another problem. People got drunk on the alcohol that they looted. Lots of communities were affected by these problems here, and even the ambulance responders were one of our by drunkards again. We don't have many ambulances, and then this compounds the issue again. Security issues across the board. On the next day, it's 7 p.m. in the night. So this is 11th. Remember, we started the response 26 hours ago, 28 hours ago. And there's still a large backlog of emergency cases that's waiting for the ambulance to respond to. A really big compounded disaster. So you can see the complexity in which our pre-hospital case on a day-to-day basis, and then when this kind of incidents happen, yeah, it's overwhelming. Okay, so I'm about halfway through my presentation, so I'll move on to the hospitals now. So Egera Hospital is located about 50 meters from the shopping center, and that shopping center is massive. There's about 5 or 6 different big warehouse structures that have shops and cars and that, and they were the main target of the residences in that area, and they were all set alight. Safety and security risks for large fire, smoke. There's a service station in that compound as well, so there was a risk that that service station would have exploded. Luckily, it didn't. So the billowing smoke and the crowds that were charging in and out of these stores forced the hospital to panic and be evacuated. The staff were not HMIMS or MIMS trained as well. So there was no contingency, no planning, no repurposing of space and stuff. They just moved all their patients to the MSF facility next door. And then all the new cases, unfortunately, was as much as they can into vehicles and ambulances that they had, and transported out of the facility and gone straight to Pomchen. The St. John team arrived around 4 p.m., but many of the cases had already been moved. So what the St. John team was, they based in the hospital yard and awaited for any other cases that came in. From this picture, you can see this red star here is the store that's near the hospital that's here. That's the distance that you can see. It's not that far. And all of these shops that I mentioned, all of them were on fire. And the service station is here. This is a video of what it was like in the yard, that area. So chaotic. He's getting into one. You'll see limping people with bandages being carried to other vehicles, non-medical vehicles, non-ambulances.
You're on.
Okay, the camera will pan back and you'll see a burns patient. And there's no stretchers, there's no way to move him, so he's on a wheelchair. So you can hear everyone is moving around, panic. The responders, because when the camera pans around, you'll see how close the smoke is. This incident. So it's about a minute long, so it'll go to the burns patient and come back. So they're trying to stack them into this ambulance here. So that's one that's not on a stretcher, proper stretcher. Multiple. This is the burns patient. So you can see from how much SSD has been applied to him, you can kind of estimate how much percentage burns he's got.
Both legs. That's
Both legs. Oh, what happened?
So 18% for both legs.
That's the burns patient. And the arms and the back.
The arm, 36%. Both arms, both legs. 36%.
So when the camera pans back this way, you'll see the smoke. I didn't get it. Okay. Anyway, the smoke shows this was, so that's why they were really panicked. You can see without proper MIMS training and H MIMS training, you really, if you have concept, that's a start. And that's where you can base your response on. Jen, like I mentioned earlier, on business as usual, there's about 800 beds, but usually we run low of blood. There's three operating theaters that we can have operating full time. Trauma bedding is high, and the overload in the hospital is well documented. You can see from this is the corridor I mentioned. There's about 10 or 15 patients in this corridor here, and one nurse is expected to be. It's it is the environment in which we work in, and we strive to maintain standards, but the demand and burden is just extreme. If you work in this facility, you won't actually feel it, but from an outsider, if you walk into the facility, you will see the problem. Yeah, bed occupancy, it's probably more 150%, because we only have 23 beds, and in any one day we get 100 patients into ED. And most of them will need admissions. You can imagine the turnover demand that's on the ED itself, let alone when we have a major incident. So at 1 o'clock, the hospital director of medical services, and there was rumors around the hospital, said, okay, there's something happening in the city. We need to be on alert, and everybody get ready for major incident. So luckily the team in ED, they have MIMS trained, and Mengu, who's one of our MIMS instructors, was on the floor at this time. And so the POMGEN at about 3:30 sent out the WhatsApp group saying this is a major incident.
Have you frozen, Gary?
Oh, this is a nice platform. Let's talk.
Oh, I think you froze,
Hi,
Gary.
did you lose me? Sorry.
Oh, all good, all good.
Okay. So when we started the major incident, what we started repurposing the space and discharged the Cat 3s from ED. So many of the Cat 3s went home, and we cleared the triage to start our sieve and sort and the initial triage from our triage area. So that will essentially tell us how many category 1s we have, how many category 2s from the onstart, because usually when you have a major incident outside, you can establish the ambulance would establish a casualty clearing area right near the in a safe area that's near the hot zone, the bronze area. But in this case, the whole city is affected. Where are you gonna put your? You cannot. It has to be the front of the ED. And many of the cases that come by vehicle, that come by ambulances, that will be pushed in by wheelbarrow or whichever method they will come to the front of the ED. So from the start of the ED, the first principle is you start your
Triage.
primary triage and you do your sorting and sealing of the patient. And then you know your numbers. And then you're already clearing your spaces in resource. You expanded your number of resource beds. Then you can allocate the beds and start to manage the numbers of cases
The
that
very
come in.
frequent.
Yeah, the surgeons, they came down, but they were with us in the ED from day one, the start. That was the on-call team, Dr. Apwai and the team. And luckily, that team is also the neurosurgical team. But it's only one specialist, the medical officer and the resident that were with the ED team the full time. They didn't leave. And then our accessory services like pharmacy, laboratory, and radiology, man, on the day, as soon as the word went out, we had immediate blood tests, immediate blood products. They were really supportive and on the toes with this major incident. Hey, what happened? Did I lose them again? Oh no, I there, yeah.
Is your PowerPoint up there, Gary?
Please share screen.
Okay, share screen.
Let me check.
PowerPoint go off.
Yeah.
Yep.
Can you see it
All
now?
right.
Perfect.
Okay.
All right, all good
I
now.
might stay in this view if you guys don't mind. And then
Yep.
is that okay with everyone?
Yep.
Rather than going to the presentation view. Okay. So yeah, so that would be the important thing. The support services in place, having the understanding of the concepts of major incident response inside the hospital is crucial as well. So yeah, the first stage is the spaces. So as I mentioned, the spaces, the triage needed to be cleared. Casualty clearing will happen at the front door of the ED. Patient ward transfers that were already admitted and in the ED had to be expedited. You had to get them up to the wards. The staff, unfortunately, due to the safety risk, there was only the staff that were available in the hospital. They were the only ones that could respond. There was one surgical team in ED and also the team from St. John's who were doing some orientation and that. They also came to Pomjet ED and also lent a hand. Okay, so in terms of system, I think the important thing was our coordination was assisted by via the WhatsApp communications that we had in the various groups. You can hear me, yeah? Can you hear me? Hello.
Yeah, you're clear.
Okay, thank you. Okay, so at about 5 p.m., the team was overwhelmed and the neurosurgeon sent out another group message asking for more, if there's any other surgeons in the around the hospital to assist. But basically, we had the ED team, the SMO for surgery, SMO for resident and medical officer for surgery that were in the ED. The first wave of in the first wave, there were 4 cases that needed cross-matched and immediate attention to the theater. And this was a chest trauma and 2 penetrating abdominal wounds, and then 1 limb-threatening injury. The DMS also issued instructions for more staff to assist. Okay, so that was the first wave. Then the second wave of casualties was starting to come to the hospital as well. Again, this was just another wave of casualties and mostly orthopedic cases that were coming in, and not officially, not through ambulance system, but other one-talk transport and other things that they started to come in. At around 11 p.m. in the night, we had 4 gunshot wounds. That was the third wave that we saw. We call it a wave because our capacity wasn't big, and any group of patients that were coming in a cluster, they were called a wave because it was already overwhelming. and compounding our problems in the ED. So by next day, the summary, the team had done a 24-hour cover. The same group of health workers, they covered the ED for 24 hours because no one could actually get to the hospital. On the next day, there was still a backlog of 11 orthopedic cases, as you would expect. So we had to call orthopedic to come in and review and said, do they really need theater, or can we make do with some other dressings and some other things we can manage them? There were several rumors of cases of women being assaulted and raped, and the ONG team took this as a priority, and they set up a pathway, and they asked the management to put out a special notice that if anyone was sexually assaulted and that during this event, to present to Ward 9 and the clinics for treatment. And also the ED team now switched from the 24-hour, now switched to the 12-hour shift rather than our normal shift. So major incident was still occurring. Hospital management meeting we had at about 10 o'clock, 11 o'clock that the next day, and just to review the past 24 hours response. And the whole ED was on 12-hour shift, as I mentioned. A few more staff started to arrive, and they were allocated accordingly to triage and also to our corridor and minor theater to help manage the orthopedic cases that were littering our floor at that time. Again, the security situation in the city was still unknown. We were even worried about our families as we couldn't guarantee food for them. So we had to buy food from where we can and put it, because the shops in our various areas were all looted and burnt. So yeah, there was also management also was trying to arrange for escorted staff pickup from and drop off, so that they will be escorted by our security team. This is the only tally of patients I'll give for the whole presentation. So we can, by the next day at 11 o'clock, this is from 2 p.m. when the major incident was declared, first wave, second wave, and third wave. The ED had recorded 28 admissions and 21 discharges. So altogether, you can see about 49 cases. 15 of them were general surgical, 15 were orthopedics. We had 8 DOAs, burns, mostly, and 1 death in the operating theater, which was just multi-trauma, polytrauma. So thank you guys for listening to all of that. But moving forward, from our understanding of major incident responses and then hospital resources that, and this is the reference that I will talk on the graph, and you can take a photo of it and then look this graph up and the research paper that it's from. But basically, you see from the sudden incident that happened in the event, surge of trauma and hospital resources for trauma goes up in wave 1 there. That's actually what we saw in the first instance. And this is actually the reason why EMTs and medical responders and teams need to respond in that first instance. So EMTs need to be on the ground if they're required within 24 hours to 48 hours. If not, they miss the first wave of trauma. And you see, as we go on, then we see a little bit later on, secondly, non-trauma emergencies, they decrease because everyone's scared to come to hospital. But their emergencies, they come steadily over time, they will increase, and that's actually what we saw. So this incident actually protracted over 2 weeks for us, because the non-trauma emergencies came and they were stacked up because various risks. Some couldn't get their medication, some couldn't access their clinics, and then they deteriorated and they came in as emergency cases. Electives were shut down for a bit until the orthopedic cases and that was settled down, and then that day eventually the elective cases and the elective resource for those cases actually went back to normal. So our response actually lasted in total about 2 weeks to get back to some normalcy of operations with the staff and all of that. The non-trauma burden, as I mentioned, was particularly heavy on us because everybody was exhausted. So we actually had to pull staff back from leave. In the first couple of days, second day, when we noted that the situation was overwhelming and we had only minimum number of staff and we had like a good number of staff on leave, we called everyone back. We started them on a 12-hour roster, and then after that, after the 12-hour roster and they'd been on the roster for 2 weeks, we said, okay, all of you can go back to your leave now, and we gave them the added 2 weeks on at the end of their leave again to compensate for them coming in. But we thank them because that was a champion effort to come in and bolster the team in the time. Final points, we need to exercise our MEMS and HMEMS planning. So MEMS for out of hospital responses, and then HMEMS for hospital major incident management, medical management and support inside the hospital. We need these courses to be taught, and we need the understanding of the concepts to be understood in almost every facility that we operate in, because anytime the sudden onset things will happen. And we need to know the principles of response. And we are fortunate because you can see St. John's had a structured response. And that St. John's response was according to the command and control, communication, safety, the first principles of MEMS and HMEMS training. And if they didn't have that understanding, their response would have been very poor and to the detriment of many more casualties. They saved us because they were able to triage out there, and many of the first aid cases they treated and they sent them. If not, we would have been flooded with all those cases. So understanding of these core concepts and principles and more training of that in PNG is something that we find is a goal for us. And over the next few months, you'll see that we are starting to bring the courses back again into PNG, and we're starting to build on this knowledge as well. So I look forward to working with a lot of you in the provinces on this. We need the demonstration of the plan, and exercising the plan will also ease the staff fear that you actually know what you're doing and there's a system to which you're doing it. Many of the staff didn't come back to work during that initial phase because they feared their safety, because they didn't actually know what would we do and how would we do it. We might go and get caught up in this thing. Our safety is not guaranteed because we need to be escorted to work and back again. So, but once we demonstrate that we are exercising the plan and that, the staff confidence will build and more staff will respond in the initial instance. And communication is essential, and for command and control, and WhatsApp was our key tool that we used. Aside from that, thank you. And I'd just like to acknowledge NCCTRC initially for all the MEMS training and knowledge and giving us the opportunity to share our experience here. St. John PNG, NCDPHA, who manage Gare Hospital, Pong General Hospital, Senior Executive Management, and the nurses, key nurses, because doctors, we don't do the work, the nurses do the work, and we are grateful to have a champion team of nurses around us, and the Mosby General Hospital Emergency Champion team. Thank you very much. Any questions?
Bola, I have a question.
Yes.
My name is Aluesi. I am a registered nurse in Fiji, but currently studying here in Sydney. I just wanted to ask, like, after the state of emergency, like when it was over, what were some of the things that that was done to help medical professionals, like, to recover in terms of psychological, like, were they given time off or were they incentivized, or like just some information on that? Thank you.
Very good question. For St. John, there was the ambulance system has a good governance system in place, so there was support provided to some instance for them. I'm not sure about the incentivization of that. We don't then that's the same for the hospital response. There was no incentivization except the extension of the leave for those that came in, canceled their leave and came in. In terms of a debrief, unfortunately, we are yet to have a proper debrief with the emergency team on this, and it's still a failure of ours to also look at this system as well about the after action review and then looking at the major incident as well as a whole. But like I said, every bad opportunity as well is a good opportunity because it actually gives us a live scenario to base our HMIMS and MIMS planning of. But it's a very good point raised, and yes, it is a gap. Admittedly, so it's a gap in the overall response since then till now.
Thank you.
Oh, acknowledgement, I spelled it wrong. Sorry. Just now.
Has anyone else got any
Apologies.
questions or comments?
But I'll take note of that comment, and yes, definitely. In our subsequent meetings, I raised it to our senior executive management in POM General Hospital, and I'm actually undertaking the task with our department here to have a look and review and exercise our major incident plan. But definitely, I will incorporate your comment in our planning phase. Yeah, it's crucial. Yeah, you're absolutely right. Any other questions, team?
I have another question. Sorry. If you had to go back, like what would be some of the things you would have changed or done to make the outcome better? Just hypothetically.
I think the number one is a better collaboration with bed managers in the ward, and especially with major incident management and repurposing space. That's why I always make the key that the response is not really doctor-led. It's a collaborative effort. I would have had the major incident plan incorporating the bed managers from the start as a collaborative group to organize and manage and reallocate beds, because there are obviously sections that of spaces that we could have allocated and utilized, but it could have been done better. Maybe you can see from the presentation the next day we still had the 11 what's the name, orthopedic cases still in the ED, awaiting transfer to the ward and then subsequent surgical management. Yeah, critical care, definitely. I agree with the psychological therapy and post-trauma issues are something that we need to address as a whole organization. I read your comment. Thank you. Very good comment. Yeah, so what I would do different is bed managers from the start, space to address the space issues. Because access block, like all of us face, we have access block in all our departments. But we won't manage it unless we collaborate. The people that you need to collaborate with are the bed managers, not talking in between us, because it won't solve it's input, throughput, and output issues that you need to look at.
Dr. No, this is Josephine from Medellin.
Yes, Josephine, go ahead.
Thank you for your presentation. I joined in a little bit late, but I just wanted to know whether we have a national disaster response plan, which in this case that plan was activated or not. I'm just interested to know.
No worries. Are you referring to health or are you referring in the general scope?
A general scope.
Okay. So for us,
Like
the
what
national
we have with the
disaster.
pandemic?
Yep, okay, so the National Disaster Management Act enables the National Disaster Center to respond. The National Disaster Center manages the operational needs for disaster response, but they
Right.
enable a National Disaster Committee, and the National Disaster Committee is chaired by the controller. So with the controller during the pandemic, it was the police commissioner. For this instance, it became the deputy police commissioner because the controller, a few other people were all suspended, remember, during that period
Okay,
to be held accountable for this incident. So,
I see.
but to maintain that, they appointed the deputy controller as the deputy police commissioner as the controller. Okay, under his powers, he reports directly to the NEC, and the NEC is the chairman of the national disaster body, and they collaborate with humanitarian partners. And the humanitarian partners form the disaster management team, which support across all boards for us. And there's a Disaster Management Act. The NDC has an SOP that they follow to respond to the disasters, and then health is part of that group. So they form a National Emergency Operations Center, and the health form a HEOC, Health Emergency Operations Center. I hope that answers your question.
Thank you very much.
Right. Thank you, Gary. That was an exceptionally interesting, thought-provoking talk, and I think just great how you covered the response from both the pre-hospital point of view and the hospital point of view, and how the added level of complexity that was added to that situation was your safety, because of the because the police weren't around to help in that aspect. And I think that just demonstrates how important it is for all of the emergency services to be working together where possible. So thank you very much. Very, very interesting talk indeed. Before we go, has anyone else got any last questions? No. What I might ask, if you don't mind, we've got lots of people attending today to listen to Dr. Gary. Would it be possible for you to turn your cameras on so we can take a photo of you all, please? Just to show how popular Dr. Gary is and how interesting the subject is as well. Great, thanks, Josephine. Rose, are you able to turn your camera on? And Maureen? If you can, that would be great.
My team here just left.
Oh, camera shy. All right.
Camera shy.
All right. Ready? Ready, steady, smile, say cheese. Thank you very much. All right.
Thank you, everyone.
Thank you. And just one last request before we go. If you can, I'm just about to drop a link in the chat. If you're able to register for this NurseTOK session, that would be really helpful. Thank you. And we will look forward to seeing you all again next month. Thank you, Dr. Gary, and thanks for all the extra work you do for the NCC TRC with regard to teaching on the MIMS and HMIMS courses. And we're looking to be in PNG later this year to deliver those courses again. So that's all being discussed.
Hopefully we'll have the HMIMS course during media here. So definitely some of you POMGEN listening in from the critical care room there will be included. Definitely, like I said, collaboration is important.
Yeah.
So all cadres.
Definitely.
Thank
All
you.
right. Thank you all, and you enjoy the rest of your day. Take care.
Thank you.
Bye-bye.
Bye.